We have a partnership in Mayo. It's going into its fourth cycle of 5 years. We're two district rural hospitals linked together, similar populations, similar environments, rural geography, rural poor, and similar desires to continue in quality improvement over time. We discovered that we can't partner on our own. We're nested in a wider community development project, and we are looking to find experts so that we don't have to reinvent the wheel for new work. And through this forum here, the Global Health and the Partnership Forums, we've learned many things over the years, and for that we are very grateful. Our entry point was peer education, training the trainer to reduce mother-to-child HIV transmission. Interesting from today's paper this morning, our politicians are finally having immediate testing for their HIV status, which is something that they probably learnt from the global HIV work that came particularly out of Eastern, Western and Southern Africa in terms of knowing your status as one of the key messages at the height of the pandemic. And finally, it's made its way up the street here to our politicians who are doing this in public yesterday, I believe. So to answer the question posed, what can Ireland learn? It's very much about the evolution of partnership over time. And the lovely thing about this meeting today is that we have people who are considering volunteering for the first or second or third time, those that have established partnerships, those that are looking for how to partner effectively with the southern-northern direction, and the Achill sheep taking shelter from the rain on the west, and the humans helping the innovative motor stay on a muddy road, are ideas of evolution that I think we should use in healthcare as well. And it's very fitting that we've heard about the reverse innovations that can come if we're open to them. And because it's the end of the session, I've cut Philip was generous with 10 minutes before lunch, 8 minutes after lunch. My colleague Una said, cut it even shorter. And Nadine, the last time I spoke with her, gave me 3 minutes. So if we look at where these global health travellers travel, I don't mean where we travel physically, obviously, and where we travel in our mind and where we travel to when we come back in our minds. So our Kenyan partners on the right, one is leading a department in the Ministry of Health, one has gone on to district management services, and one has come out of retirement to go back as a coal-faced director of nursing in a small general hospital. And our partners on the left, they're going on to take higher roles in education, to take roles in hospital management, or to go back to the clinical coalface refreshed with ideas that they bring to work every day. And I think certainly from hearing from the short presentations this morning, it's how we bring it back to our workplace, how it refreshes us and gives us fresh eyes, and how we can cut some of the fat, and hopefully Dr. Firth will help us cut more fat over time, but how we can cut the fat in what we have. And I guess that's how I'm going to look at some of the things that we are learning from what we've done in our partnership. So who are the quality improvers? In our own institutions, we're all in different institutions or workplaces, and our quality improvers are every member of staff who chooses to be a quality improver. Because I guess you either have to be a quality improver or a quality improvement blocker, or am I too binary in my thinking? And if we develop an education course to teach, as this very successful CORP program for which we've copied a few of the Helping Babies Breathe, the newborn resuscitation, the essential obstetric skills, if we can devise a course that we can deliver and scale up widely with small resources, then why do we need to do the high-tech type of education in our own environment when at the end of the day we're teaching the same skills? The skills to keep mums and babies alive are the same all around the world, and the skills in the first 10 minutes don't need high-tech equipment. So we learned from our work in Kenya that if we use the exact same course, essential obstetric and newborn care course that we used in Kenya, in a rural community in Kenya, if we use that in Mayo for the 15 new GP trainees that come through our unit every year, we were able to deliver that, whereas we weren't able to get them through off-site training or high-cost training or training provided by external providers, because we just couldn't physically sort the logistics to get every trainee through that program every year. But by delivering what we had honed down to pure essentials when we were away, because I think we think much more clearly away, don't we, than when we're at home, we were able to work on how we'd work our induction program for the GP trainees in our unit, as we often don't have obstetric trainees. In this room yesterday, there was a Women's Health Symposium to learn from what's happened within the cervical check in Ireland and to learn what's happening with the global burden of cervical cancer and how we should be looking to eradicate cervical cancer. And one of the questions and themes is, where does respectful care begin? And when we might be motivated as healthcare providers to engage in partnership, we're often thinking about, how can I fit in somewhere else? And have I something that I can learn? Do I want to learn more tropical medicine? Do I want to learn better resource management? Do I want to learn about global diseases? Or do I want to see how others have used those opportunities for learning and translate them then into what we do at home? And in all my toing and froing and involvement in partnership work, I keep on coming back to girl education. Now, I'm a women's health provider, and our entry point was through the Women's Health Maternal Survival Programme. But we know that survival of babies and infants and children depends on the level of education of the mother. And we know that if we can keep this young girl in school until she's an older girl, a young woman, that then her children are more likely to survive or more likely to go to school, and then society benefits because she has been educated. But the respectful care of how those mothers are educated is, how do we bring them to the table in our own environment? So in our national quality improvement programs, where we're talking about patient experience or person-centred care and looking at how staff are engaged to be able to partner with patients in this country, and we've not done that well in certain areas, and particularly in my own area over the years. I think our refocus on the girl child and how she's educated. And I don't mean that in what's happening in men's health and the man child, the boy child, but just we know where there's still gender gaps in Ireland. And if we read the gender gap reports, we still have economic and social power gender gaps, even though our health and education gaps are fairly reduced. And so I think we have to look outside health in our learning to come back to Ireland with the benefits that we've learned in our partnership. Little examples, if we're involved in setting up perioperative services in a new setting, we think about who needs an operating room and the gap that's there when we don't have an operating room. But if we flip that question and then ask the same question, who does not need an operating room? When we come back and we know that we don't have enough operating rooms for everything we want to do in the operating room, we realise that our partners are operating on, in my case, in women, without an operating room because they've kept them ambulant, they've used local anaesthetics, they've used conscious sedation, and all these things that we kind of dropped over the years are now coming back into our practice. So we have looked, by being involved in a perioperative program setting up surgery, it also allowed us then to develop an ambulatory gynecology unit in Mayo that sees about 6,000 women a year, where the women will stay ambulant if they've got the right healthcare support staff with them through their care. When we're looking at planning for a service next year that we don't have the resources to roll out in such a way, we have to think about ambulant options for them as well. And the reverse technology of manual vacuum aspiration and miscarriage and early pregnancy work, including termination, is one of the skills that can bring to the global north and what the global south has been using for many years. And in the cervical cancer eradication, and again a headline from today, our cervical cancer screening program is under threat because of problems that were identified duly in the program. But we only need vinegar and cotton wool and being able to freeze a cervix to reduce death from cervical cancer. But we have to do it in a way that our population accepts and expects and feels that they're being treated humanly during their treatment. And so we sometimes lose the bigger message in the smaller ways that we present our healthcare opportunities in Ireland. But I think when we've seen through the lens of global health and see how our colleagues work with different opportunities for resource, we can bring that back to our setting and become thinkers in our own local environment, whether it's in primary care as a contractor, whether it's in a hospital situation, or whether we move into a different sector entirely. And coming up to my last theme is who's at the management table. So we know that we'll have different directors and different improvers and different managers and different heads of different clinical and healthcare social professionals. But where are the women and the girls? Where are the community users? Where are the youth? Where are the vulnerable men? If they're not at our management table, then I think one of the greatest learnings we've had in our Kenyan partnership is that the hospital committee was chaired by a village elder, that they always had a representative of youth and of women, and of the tribal minority group in that particular community, because the tribal issues, it was a flash area during the post-election violences in Kenya about a decade ago. And our management teams will sometimes say, oh, we're not really ready to have a member of youth, a member of women, a member of vulnerable groups at our table. But if we say that, and if we accept that as a reason not to have them there, we're never going to be ready to have them there. I can't say for our hospital team, we've had different iterations of our management teams over the years. Different patient focus groups, forum groups have been set up. But I can say that slowly we're working at having a patient or a family or a service user on every committee in our hospital in Mayo at the moment. And some of that learning has come from our partnering with Kenya, and because the committee was chaired by the local village elder, chaired beautifully by the local village elder. I think in the interest of time, I will skip the joining the dots. And my simple answer to all these questions that have been covered by you, the experts in the room today, is that I think we can learn everything through Global Health Partnership, but I'm always interested in keeping things relatively simple. And if we are looking in the right way with the right eyes and asking the right question, I think all the answers are there through Global Health.